Are we okay for a go? Hi, folks. Well, I hope you can hear me. This is Dr. Bob Ross, California Endowment, a member of the California Health for All Commission, and we just wanted to kick off this Community Voices event. I was hoping and intending to be in my office in a more comfortable setting to join, but the traffic gods were not with me today. So I'm literally at the pull over, and I'm in the parking lot of an El Pollo Loco in Southgate to to greet you. Um, but hello, everyone. On behalf of two of my colleagues on the commission and fellow foundation presidents and CEOs, Dr. Sandra Hernandez of the California Healthcare Foundation and Antonia Hernandez of the California Community Foundation. We worked in partnership with Dr. Mark Galley, our state cabinet secretary for Health and Human Services, and his team supporting the commission to make sure that community voices were heard as we embark on an effort to bring recommendations to the governor about how to reform and transform California's health system. And I can speak on behalf of my colleagues, both Sandra and Antonia and myself. Too often we get in these conversations around reform of the health system and health policy as it relates to health. And it's too often an elite conversation. It's too often including people who are CEOs of health systems and people from Rand and Harvard and UCSF and UCLA, and of course we need people like that know the intricacies of the system pretty well. But we felt strongly that we really wanted to hear from real folk that are engaged in the health system on a day in and day out basis, bringing their voices, bringing their experiences, bringing their wisdom about what they want to see in a future health system in the state of California and ultimately for the nation. And so that's what the Community Voices engagement was about. You'll hear from our colleagues today what we heard from so many of you and those that were engaged in this process about the good things about our health system and the difficulties and challenges as well. And so with that, I believe I'm handing this over to Dr. Mark Galley. I'm not sure, Mark. I hope I have that handoff right.
I think you do, Bob.
Yeah. Okay, but once again, on behalf of the California Healthcare Foundation, the California Community Foundation, the California Endowment, and thank all the staff for putting this together in record time, particularly Marisol Avina from our team. But Mark Galley, thank you for your partnership and your leadership, sir, in opening the ear and channels of the governor's office and the commission to community leaders and community residents who want to see a better health system for California.
Thanks, Bob. Sorry, do people have the echo that I have? All right, I'm gonna power through. So Bob, thanks, thank you. And let me just say to Antonia, Sandra, Bob, all of you and your teams, the foundations that stepped up, just really debt of gratitude. You came in and really helped us figure out how to do a piece of this commission that we didn't want to let go. The pandemic really moved the work of the commission on a different timeline, changed the way we did it in many ways. And we were nervous we would lose the chance to really bring in the community voice piece that, as you said, Bob, I knew from the beginning when we chose our meeting times to be smack in the middle of a workday afternoon, that some of the voices we needed to be part of this conversation would be missed. And I am just grateful for all three of you and your leadership and the teams and stepping up to get this done, like you said, in record time. And the commission really, I think it started in a certain way, and because of what we've all lived through during this pandemic, I think is shaping up in a slightly different way. and the consensus that's being built around the need to really aggressively move forward with equity as a centerpiece of our healthcare delivery system has just been really incredible. I think to see that transformation just in our own meetings, and I'm looking forward to highlighting that more in the meetings to come, and then just in our final report. This piece of work, the community engagement, the community voice, to me was also such a centerpiece of what we've been able to do. The week it was presented in the webinar, and then the subsequent week when we talked about it as a commission, I think it moved the needle in such a significant way. And I don't know if the three of you foundation leaders who happen to be commissioners with me on the Healthy California for All Commission sort of recognize or feel the same thing I did. But even in last week's full commission meeting, you could see the fingerprints of this work on those presentations, and the tenor and tone, the conversation, the follow-up questions. And it made me smile and really proud that this work, I believe, is having an immediate impact on what we saw. And I think on two levels I'll highlight. First, that the issue around healthcare and healthcare affordability is not a new issue. It's not an issue that is sort of coming on and off Californians' radars, especially low-income Californians in communities of color, that this is a lasting issue. And the fact that it stays there says that we need to continue to move forward the work of the commission and so much else to really unashamedly push reforms and transformations that help us focus on the needs of those Californians so often overlooked in the conversation. And that authentic community voice is something that is poised and ready to not just inform with words and statements, but to really roll up sleeves and be at the table when the actual design of the systems come together, and not just kind of what care is paid for and what isn't paid for, but who's delivering the care and where that care happens and how it's accessed. I mean, all of those details I heard pretty loud and clear, that not only should we create a place at the table, but we should insist on that being a very regular part of the discussion. And then also that you heard in the comments in both the more qualitative and quantitative parts of the work that we're going to hear about more in the moment, is that this health system that we have in California is failing many. And it's not just failing many on the outcomes, but it's failing many on the experience and some of the things that I think we may even give ourselves more credit than we deserve as to where we are. And that this is an urgent part of the reform that we have to focus on and work on. And the last thing I would just say is that the work that this effort, the influence on the commission, I think is real and impactful, but also that as we think about the conversations that happen immediately after the commission report comes out, is that the role of community voice is essential for us to continue to think about how to engage, that it's going to take resources. We can't just depend on you all, although I know you will continue to step up and help us, but any broad reform conversations and transformation conversations has to set aside the funding, the time, and the space to continue to engage the voices I think we've started to bring to the table through this work. And then as chair of the commission, as somebody who anticipates having at least 3 more meaty, lengthy conversations with my co-commissioners, that the chance to be engaged in public comment, to share your thoughts and feedback, if it works on people's schedules, if it works on people's agendas, to be part of those conversations. I urge all of those who are tuning in now to consider joining those meetings, having your voice heard, even on the issues that we talk about in those specific meetings, because it gives us an opportunity not just to be reminded by the power of that voice, but to really never forget how we needed to continue to imprint our own ways of leading this work in the months and years to come. So with that, I am now not sure who I turn it over to, whether it's Sandra and Antonia. Sandra, is it you? It is. Okay. Seeing ahead now.
I think it's Antonia, actually.
Oh, Antonia. Okay.
And then I'll take it from there. Thank you, Mark.
Okay. Yeah, thank you.
Well, first of all, I would like to thank Dr. Galley for your leadership. This has really been, for someone who's not in the health field, a really wonderful educational experience on the complexity of healthcare coverage. And I also want to thank and acknowledge the leadership of Dr. Ross and Dr. Hernandez. I've always looked to you two who are in this field to provide leadership and guidance. My comments are more from an outsider perspective and from a perspective of making sure that everyone is covered, the undocumented population, the uninsured, that everyone is treated with dignity. We have been on this road for many years, and from an outside perspective and from a community foundation perspective that funds community clinics, we know the important role of community clinics. And so as I understand and learn and look forward to a program, to the development of a policy of legislation that covers all Californians, and that we, from the beginning, when we develop this new coverage for all, that we take into consideration the dignity and the respect of all individuals, not just those who have insurance or who can afford to pay. I'm mindful of the complexity. I am mindful of the cost, but I really think that this commission, if thoughtful, if listening to community voices, we can come up with a way to lead the nation and the world in making healthcare a civil rights issue, a human rights issue that all should enjoy. And with that, I turn it over to my colleague, Dr. Hernandez.
Thank you, Antonia. Secretary Galley, my colleague Bob Ross at TCE. I want to welcome everybody who's joining us today. Maybe just build off a few comments that my colleagues have already shared as commissioners. I do think that Secretary Galley's observation about the commission, its dynamics, the input that it's getting, really has pivoted quite a bit to focus on the kinds of issues that we heard from this community engagement process. That I think is super important, as Bob referenced. We talk a lot about inclusiveness and equity, and yet often the voices of folks that are most poorly served by our existing system are rarely at the table. And this effort, which my colleagues at TCE and the California Community Foundation and a little bit of our staff really did a yeoman's job to reach into the community in the midst of the pandemic and really hear from folks that, generally speaking, are not at the table and whose concerns and issues are often given very little voice, let alone seriously contemplated in a roadmap that anticipates a much more inclusive, simple, dignified, integrated system where really everybody is in and treated respectfully. The lessons that we learned from the various efforts that were part of this, I think, are incredibly insightful and really valuable to the Commission's work as we move forward. Cultural competency, language, really understanding how information flows from an integrated point of view. These are all important messages as we think about a significant redesign of how we think about where we deliver it, and how we deliver care in a way that gives us really much better outcomes for all of our efforts. So with that, it's really my pleasure to introduce the panel who is going to review their findings. They'll provide an overview of the process and the methodology that was used to develop this research and this input. Kieran Savage Sangwin, who's the executive director at the California Pan-Ethnic Health Network, a statewide multi-ethnic advocacy organization that really does amazing work. And I know all of us in the health philanthropic field really rely on Kieran and her organization to give us a critical input. She'll be followed by Dave Metz, who's partner at FM3 Research. That's a California-based polling firm, and Dave will share findings from recent statewide polling and some of the online discussion sessions with Californians with low incomes. And finally, the panel with Paul Hernandez, who's the Chief Strategy Officer at Fenton Communication, a social change consulting firm. He'll share findings from a series of interviews and listening sessions with a number of community-based leaders. With that, I'll just remind folks that if you have questions for the panelists, please put them in the chat for Q&A. And with that, I'm very happy to give the program over to Kieran. Thank you. Very nice to be with all of you this afternoon. Kieran, over to you.
Great. Thank you so much, Dr. Hernandez, and and thanks so much to those of you who are joining us today. As was said, I'm Kieran Savage Sangwin, the Executive Director of the California Pan-Ethnic Health Network. We are a statewide multicultural health advocacy organization. We were founded in 1992 to advance health equity and racial justice by building powerful coalitions, shaping narratives about equity, and advocating to state and local governments for change. And today, what we will be presenting is a summary of various research that exists. And so I definitely want to say it's not comprehensive, and particularly when we think about the diversity of our communities and the depth of experience, this is not comprehensive, but it is a snapshot. And we hope it'll be helpful. I'll just say a couple words about the process for this project so that folks have that context. And so the goal here was to enhance the ability of the Healthy California for All Commission to ensure that advancing equity is central to a potential shift to a unified financing healthcare delivery system in California, and to highlight the experiences of Californians with low incomes and Black, Indigenous, and people of color, people whose voices are not always heard at these meetings, as Dr. Ghali said. The project started with a look at the existing body of research on consumer experiences and priorities, and we learned that although the research is extensive, there are also gaps. So the project built upon existing research with a statewide poll, which Dave will talk about, and additional interviews with community leaders, which Paul will talk about. So I'm going to make sure that we stay on time here. I'm going to dive right in. So I'll say for the research that I'm presenting, we looked both at some sort of broad data that exists on health equity and health systems and the perspectives of consumers, but we also tried to dive into some lesser known data that comes directly from communities, including our own research at CPEN with communities of color, people with disabilities, and LGBTQ+ populations. And I definitely want to give credit to the community partners that have been deep in this with us, folks like Black Women for Wellness, the California Consortium on Urban Indian Health, the Latino Coalition for a Healthy California, and many others. The themes that we saw in the existing research are largely very consistent with what Dave and Paul will talk about. So it's, I think, helpful to see the alignment, but there are also some areas where there are new findings that they will point out. So I'm just going to catch up on the slide deck here. If we can go to the next slide, please, and then the next slide, and then the next slide. I get carried away with what I'm saying. So, okay, perfect. Thank you. So I will also say for us as CPEN, we see equity as a primary thread throughout different issues when we look at healthcare, not necessarily as only one component, but really the core of everything that we do. So the first piece that really came out as a theme in some of the research that we looked about was around healthcare coverage and affordability. So no surprise there. And that healthcare affordability is a major challenge as well as a top priority for Californians across coverage types. A little bit less for Medicare beneficiaries, but generally across coverage types. And 80% of Californians rate making healthcare more affordable to be very or extremely important. And I want to say this includes specific concerns about lowering the total cost of care, so premiums, copays, and deductibles. It also includes making prices more transparent to consumers, ensuring universal coverage, and avoiding unexpected consumer costs, which is one significant worry that many families have. And when we talk about cost and affordability, we're talking about the actual costs, right? Again, so those premiums, the copays, the bills you get, but we're also talking about perceived costs that may exist. So when consumers have confusion about their benefits and coverage, there may be things, and we see this particularly for mental health, that people think will be costly, even if they are in fact meant to be covered by insurance. It also includes costs that result from access barriers, such as out-of-network providers, when folks need to see an out-of-network provider because they couldn't get to an in-network provider, and unpredictable costs, like surprise bills and annual premium increases. So we have recommended, because of this research, that the commission consider not only who and what is included in a system of unified financing, but also how consumers are informed of their coverage and benefits, that we also include assistance with navigating care. Our community-based navigators are very important to our system of care, and flexibility in systems to identify and fill gaps as they emerge. Next slide, please. Can we jump to the next slide, please? Oh, can we go back? The one that says access on top. Perfect, right there. So access to care, another key theme of the 4 that I'm going to highlight. This is the second of the 4. So as you all probably know, there's still a gap between what exists on paper and what people are supposed to have access to and what is actually available to consumers. And that health insurance is a necessary but not sufficient condition to ensure access and to advance equity. So we need everybody covered. We need everybody in the system, but that on its own is not going to get us to health equity. A couple of the things that come up a lot from consumers, one is that provider networks are still quite inadequate, both in terms of sheer numbers, but also in terms of diversity. And that provider networks are often inaccurately represented to beneficiaries as well. So folks are probably familiar with provider directories that contain outdated or erroneous information. So a key question for the commission is how, in a unified financing system, we can ensure access to an adequate provider network. And what options will be available to consumers in terms of provider choice and information. We also know that access to mental health, substance use, and addiction treatment are some of the most difficult services for consumers to access, in addition to dental care and long-term care. And dental is particularly challenging because it's very limited within most coverage types, right? And so it's a good example of the challenges that consumers face when certain benefits are not provided through the same system, right? And consumers are sort of left on their own to figure out how to access that care. And the final point on access to care is that, there's broad understanding and agreement that non-clinical factors, or sometimes we call them social determinants, have an outsized impact on health. But some of the research does show that there are mixed feelings from consumers about the role that the healthcare system should play in addressing social determinants or drivers of health. And that's largely based on a hesitancy around the poor performance of the healthcare system currently for people with low income. So people saying, hey, the existing healthcare system can't find me a doctor. Why is it the right system to rely on to help me with my housing, right? So next slide, please. Perfect. So we also looked at clinical care experience. So again, this idea that you can have insurance, you can even get to the doctor's office, but for people of color and people with low incomes, that experience of clinical care is not always positive. And so as we redesign systems, we need to think about what are the key components that really keep people healthy and help people have a positive relationship with a healthcare provider. So there's numerous bodies of research, including CPENs, that find that people of color, in addition to people with disabilities and LGBT people, continue to face stigmatizing, disrespectful, and discriminatory treatment in healthcare settings. This results in inappropriate and ineffective care, and sometimes also results in consumers being hesitant to seek future care. Consumers often feel that there's no recourse for these experiences. Even though there are legal protections in place, we have strong laws in California around non-discrimination, around language access. Consumers don't have a sense that there's a way that they can utilize those to assist them when they face a challenge, right? Sometimes the grievance procedures are complicated, or people don't trust that they will work. Sometimes they have failed people in the past, right? Another point is that consumers tend to want a more continuous relationship with a primary care team, want to have a place that you go for most of your care where you know them and they know you, and that consumers often desire to have care navigators, coordinators, and advocates as part of their team, in addition to clinicians. Some consumers prefer that there be a physician as sort of the core of that team, but not all consumers share that preference. And many consumers who we talk to want more culturally and linguistically appropriate care, as well as more integrated and co-located care. So both physically integrated, right, co-located, and integrated as in the providers are able to communicate with each other and have a holistic view of your health. So one question that I think is challenging, but also very important for the Commission, is how can a system of unified financing pull different levers to enhance the experience of care and healthcare outcomes for diverse Californians? For example, in a unified financing system, how can payment reform better incentivize culturally tailored, integrated, continuous, and person-centered care? And another question is, how could a system that utilizes a unified financing mechanism have stronger enforcement and accountability mechanisms for key consumer protections, such as non-discrimination, language access, and timely access to care? Next slide, please. So the fourth and final sort of overarching theme of the research is about consumer information and engagement. And I think, you know, it's very clear that the Commission and the Secretary are committed to and focused on equity. And for us at CPEN, when we think about equity, equity is about power. And so achieving health equity must involve building power and shifting power. Consumers have to have equal power in the healthcare system in order for it to meet the goals. And that means that we need to correct the current dynamic where consumers often feel that the system is designed around profit incentives for plans and providers, not around the needs of consumers. What we see in the research is that consumers want to be more involved in their individual healthcare and have more empowerment around their individual health decisions, but they also want to be involved in the design of the system itself. And in order to do that, they really want to see their feedback result in measurable change, right? Not just an extractive process of gathering input, but really thinking about how the feedback leads to the changes that we seek. So the Commission could consider how the governance structure of a new system creates more opportunity for consumers to have real decision-making power, particularly people of color and people with low incomes. So that's real quick. Those are some of the key themes that we see. My colleagues are going to delve more into detail, but I do want to say, and Dr. Ghali touched on this just as a closing note, that this project was done on a very short timeline, and so it didn't have the most robust engagement of communities that we would like to see, right? An ongoing process of engagement and deliberation. So we really were only able to sort of gather information and opinions and report them back. So certainly CPEN really encourages the Commission to consider additional opportunities for community engagement and discussion as it moves towards recommendations on a unified financing system. And with that, I believe I'm going to turn it over to my colleague, Dave Metz.
All right, fantastic. Thank you so much, Kieran. And I'm Dave Metz with FM3 Research. I'm going to talk about the next phase of our exploration here, which was to conduct some new survey research to explore the attitudes of Californians with limited incomes toward potential changes in the healthcare system in California, to try to understand what barriers and challenges they currently face and what types of steps they think would be most effective in addressing those barriers. As Kieran said, there's an incredible amount of consistency between what she and her team gathered from the existing body of research and then what we learned from our current survey. But hopefully this helps to put a little bit more of a precise sort of numeric point on some of the attitudes that these Californians have about ways to improve the health system moving forward. The data that I'm going to share with you today, as you'll see on the next slide, comes from two different research projects. The bulk of what I will share comes from a survey conducted among nearly 2,000 Californians with incomes under 250% of the federal poverty level. It was conducted in late August and early September. This quantitative survey research was preceded by a couple of online discussion boards, one in English and one in Spanish. Again, with a diverse set of Californians with limited incomes from across the state, where we asked more open-ended questions to try to understand some of the patterns of thinking that lie behind the survey responses that we gathered in the second phase. In order to make sure that the survey gathered responses from as diverse and representative a group of Californians as possible, the survey was conducted across multiple modes. We used landline phones, wireless phones, emailed invitations, and texted invitations to invite participation from respondents, and the responses were gathered through a telephone survey and an online survey. The survey was conducted in English, Spanish, Chinese, Korean, Vietnamese, Tagalog, and Hmong in order to give us, again, as much ability as possible to make sure that language barriers did not stop Californians from having a chance to participate in the survey. So, as Kieran noted, the research had to be done on a very aggressive timeline, but despite that, I think we were able to get a very broad and diverse set of voices from Californians to hear what they think about these critical issues. So the next few slides will tell us what we learned. To start with, on the next slide, we asked our respondents to rate their level of concern about a variety of issues facing California right now, rating each as either an extremely, very, somewhat, or not too serious a problem. We've ranked the responses here by the proportion who rated each issue as either an extremely or very serious problem, the top 2 points on that scale. And you'll see those numbers running down the right-hand side of the slide. And so among these Californians in households with limited incomes, it's clear that affordability was a major concern. Among the issues that they ranked as the most pressing problems facing California were the cost of housing, the cost of living, and as you'll see highlighted midway down the slide, the cost of healthcare, alongside COVID and homelessness as major concerns in the state. At least 3 in 5 Californians that we interviewed rated each of these items as an extremely or very serious problem. And among concerns relating to healthcare across the data, we saw issues related to cost and affordability repeatedly stand out as the major concern that Californians would like to see addressed. In fact, as you'll see on the next slide, when we asked our respondents to evaluate a series of different changes that they might like to improve healthcare in the state, and we framed this as an open-ended question so that they could tell us in their own words what was most important to them. The single most frequent response that we heard was reducing costs, making healthcare more affordable, or making it free for all Californians. 3 in 10 offered responses in that category. Another roughly 1/4 of those polled, 24%, specifically called for universal healthcare or expanded coverage or more services. Again, factors which would reduce the cost of accessing those services for most Californians. So it's pretty clear that affordability is a central concern, and when asked to think about improving the healthcare system, addressing those affordability concerns is at the top of Californians' minds. On the next slide, we dug a little bit deeper into some questioning related to the types of changes that we could make. And it looks like this slide is a little bit cut off here in this presentation, so I'll try to verbally describe what's on it for you here. What we did was we offered the respondents a list of a variety of characteristics that healthcare leaders might aim for in improving the way that healthcare is delivered in California, and asked them to rate each as either an extremely, very, somewhat, or not important objective of making improvements to healthcare. The first thing to note is that everything on this slide is viewed as highly important to the Californians that we interviewed, with more than 3/4 rating each potential objective as very important. The ones that stood out on top of the list, though, with well over 50% rating them as an extremely important objective, include providing safe and effective treatment, treating patients with dignity and respect, treating everyone the same regardless of income level, race, ethnicity, or documentation status, and involving you in decision-making about your care. Other items that solid majorities rated as extremely important include providing care designed to meet your unique health needs, focusing on helping you prevent health problems, and being low cost. So we've got those issues around affordability, but also a number of the issues that Kieran mentioned in her summary of the existing body of research, really showing the concern that people have about discrimination and about fair treatment for Californians of all backgrounds. Ensuring that stood out to our respondents as an extremely high priority. Now, of course, when you look at this list and see that there are so many things that Californians understandably want from an improved healthcare system, the question becomes, well, if all of these are good things, what is most important? And so on the next slide, you'll see the results of a question where we asked our respondents to choose between several major categories of improvements that might be made, and rate each item as either their first choice as being most important or their second choice as next most important. These are tough choices. I think it's clear that Californians would like all of these changes to take place, but the one that seemed to stand out most to them was making healthcare affordable for all patients. 30% of those polled made that their first choice, an additional 19% their second choice. Almost half of the Californians in low-income households who we interviewed put affordability as either their top or second most important objective. Now, we also wanted to understand how these changes might take place under the framework of creating a single unified health system where all Californians would get their health care. And so we gave the respondents, as you'll see on the next slide, a description of what this policy might look like at a very high level. Obviously, the details of how such a system might be structured are critically important, but we wanted to test it at a conceptual level. So as you'll see, if we can advance to the next slide, we had 65% of the Californians we interviewed told us that they would support the concept of replacing Medicare, Medi-Cal, and Covered California and private insurance with a single statewide government-run program that would cover health, physical and mental health, dental, vision, and other services like alcohol or drug use treatment for all Californians. That idea was overwhelmingly appealing to respondents, 65% in favor, including half of all Californians in low-income households, telling us that they strongly supported this potential change. Only about 1 in 5 indicated opposition. We did the same exploration and testing in our qualitative research, and on the next slide, you'll see some examples of things that our respondents told us in their own words were their reactions to the idea of having a single state health program. Lots of enthusiasm about simplifying the system, removing the distinctions between being in and out of network, eliminating a lot of the bureaucracy and red tape that bogged down access to healthcare, but also some respondents questioning whether this would mean the elimination of even healthcare plans that some Californians view favorably and have positive reactions to, and noting that that change might make it a little bit tougher for some Californians to get behind. Now, as broad as the overall support for this change is, it's also striking, as we'll see on the next slide, the degree to which that support cuts across most major subgroups of Californians with limited incomes. These next couple slides, each horizontal bar will represent support for making this change among different subgroups of Californians, with the total support and opposition tallied on the right-hand side. So here you'll see that there is strong support across racial and ethnic groups in the state, with Californians of color at 72% offering broader support than white Californians, among whom 54% indicate support for the concept, but majorities cutting across racial and ethnic lines. On the next slide, when we subdivide our respondents by age, by gender, and by their sexual orientation, you'll see strong support across categories, a little bit more support among younger Californians, very strong support among LGBTQ Californians, but again, majority support among all the gender and age subgroups we're looking at here. On the next slide, breaking out these responses by the type of insurance that respondents currently receive. Regardless of whether respondents are uninsured or the type of insurance that they are currently covered by, excuse me, we have majorities who indicate that they're in favor, including a 62% majority of those who currently receive health care through their employers, indicating that even those who are privately insured are generally open to and positive about this potential change. And then on the next slide, looking at it by income group, homeownership, and among those Californians who are currently living with a disability, very, very solid support across the board. Minimal differences by income, slightly higher support, but really a margin of error difference among the lowest income households within our sample. And we should note, again, our sample was limited to Californians below 250% of the federal poverty line. That means the higher income households within our sample also have larger household sizes, as that is how that poverty level is determined. And then finally, on the next slide, we look at the responses broken out by geography. Somewhat higher support in some of the more urban areas in the state, but every single region of California, we have roughly 3 in 5 Californians with limited incomes telling us that they are in favor of making this change. Now, a critical question, aside from the structure of this policy, is how it would be paid for. And so we offered the respondents, as you'll see on the next slide, a brief summary of one potential financing system, which would eliminate out-of-pocket costs for health insurance or dramatically reduce them, and instead finance the system through taxes. With a progressive structure in which higher income people would pay more as a proportion of their income, lower income people would pay less. Overall, the system was broadly appealing to the Californians we spoke with, 65% indicating support, roughly both the same breadth and intensity of support that we saw for making the change as a whole. So this type of financing system is one that is equally well received as the notion of shifting to a single state-run health system. Finally, we also explored some potential features that a statewide single health program might have. And we asked the respondents for each one, as you'll see on this next series of slides, to indicate how important they believed it was that a single statewide health system have each of these characteristics. Almost all of these are things that are desirable to the respondents, but there are some differences in the urgency that they assign to each of them. Some of the things that are at the top of their list, with outright majorities rating them as extremely important characteristics for a statewide system to have, included providing mental health care, dental and vision care, having a doctor who listens to you and respects you as a person. Again, we saw how important that was in general to our respondents earlier and in the research that Kieran cited. And then at least 50% rating it as extremely important that every person who lives in California who wants it have access to health coverage through such a system. The middle tier of characteristics on the next slide are all items that somewhere between a total of 70% and 3/4 of our respondents rated as either extremely or very important. Not a lot of huge distinctions between the items on this slide, but things like making it easier to get appointments, eliminating out-of-pocket costs, providing access to doctors and healthcare workers who speak your language and understand your culture, all very important to the Californians we spoke to. And even in the lower tier of priorities, which you'll see on the next slide, virtually all of these are items that broad proportions of the public are enthusiastic about. In fact, in every case except one, we have at least 60% of those polled rating each item as extremely or very important. The one that trails on the list here is eliminating private health insurance companies. 50% view that as important. Only 20% dismiss it as being unimportant, but less urgency attached to that change than to many of those that I think are a little bit more descriptive of the kind of benefits that Californians could expect to receive from such a system. So overall, I think this original research really reinforces a lot of what you heard described in the previous section in terms of Californians' priorities for making improvements to the health system. I'm now going to hand it over to my colleague, Paul Hernandez from Fenton, who's going to talk about outreach to some community organizations that work on these issues to explore their sentiments on these issues.
Thank you, Dave. Good afternoon, everybody. I'm Paul Hernandez. I'm with Fenton, and we had a slightly different but related charge, which was we wanted to hear from community groups across California who had experience advocating for folks with low incomes, who had expertise, knowledge, and hear regularly about the challenges that folks with low incomes experience with the healthcare system, to be able to get their perspective about what needs to change, what needs to be preserved, but more importantly, where do we go? And so if you go to the next slide. And so, we basically did two types of ways to collect that information. So, the idea was for us to talk to community-based organizations, advocacy groups, folks who work at community clinics, folks who had real direct knowledge on the ground from a lot of these same populations that we've been hearing directly from. And so what we did was two things. One, we did a series of interviews with 34 community-based groups from across the state. And then we also had surveys that folks responded to that also gave us a lot of real insight and data. And for those of you who are on the phone, who may have participated in some way, either in an interview or on a survey, thank you so much for doing that, for your candor, for your expertise, and more for your commitment around these issues. And so it was clearly, with a state as diverse as California, it was important that we were able to capture organizations that represented different rural and urban areas across California, different regions, whether it be the Central Valley or Southern or Northern California. But then clearly from a demographic standpoint, when we think about not just racial and ethnic, but the LGBTQ and disabled communities, and making sure we heard from representatives of all those different groups, because we certainly know there's unique needs and important things that need to be surfaced when we're thinking about all those different diverse communities across California. Next slide. So overall, we heard a few things which I think are consistent with what Kieran and Dave were speaking of. One, folks talked about the lack of affordability with the existing system, being able to flag the fact that there needs to be a greater need to deal with social determinants of health, particularly when it comes to Californians with low incomes, because it's a lot of these other issues that impact their well-being and their health. It's not just whether they can get to see a doctor, but it's all these other issues related to income level and poverty and public safety and a lot of other things that they deal with. The fact that many of them experience extreme difficulty navigating this system, which is entirely too complex. There was quite a bit of conversation about cultural competency in particular, and just real core racism that folks deal with the system, but also real severe workforce shortages that oftentimes disproportionately impact this population. Next slide. So a few particular attitudes that emerged about this idea of a single unified healthcare system. The first thing has to do with what value are we ascribing to a new system? And what folks told us was that we need to see healthcare as a human right, that that if we're going to see any fundamental change in the way a new system would operate, that has to be at its core. There was significant conversation that folks brought up about the fact that our current system is primarily built on profit. It's primarily built on financing, and that has a fundamental impact in terms of the kind of care that gets delivered. But that if we start to think of healthcare as a human right, we start to think about healthcare around how are we ultimately improving people being able to live longer, more successfully, in a more humane way, that's going to have a very significant difference in terms of how the system operates. So that was one big thing that came up. There was certainly support across the board for a universal and comprehensive care coverage system that included a number of different types of coverage, whether it be mental health, physical, dental, so on and so forth, but also thinking about in-home care and substance abuse treatment. Many of the folks explained that it's important that we not lose the gains that have been achieved, particularly through the Medi-Cal system, that we need to maintain a lot of consumer protections that have been fought for, that have been important, that have been able to support low-income populations, and that we need to carry those over. It doesn't mean that we need to keep Medi-Cal per se, but some of those same protections should be transferred over to any new system that's developed. There was certain significant criticism about employer-based coverage, and that particularly for folks who have low incomes, it can be inconsistent both in terms of availability, the level of coverage, and it's often very costly. And then they also talked about that we need to try to do something that's a lot more simple and straightforward, and not make it quite so complex as the system that we currently experience today. Next slide. So in terms of cost and affordability, I'll go back one slide. Thank you. What we heard from many of you was that the new system should eliminate copays and premiums. That it becomes a huge barrier for folks to get the care they need. That particularly when you're talking about folks who have a significant need for regular care, that they often will forego care or not get as much as necessary care because they can't afford the number of copays that come with that. And that there was disagreement with this idea that that nominal copays are a good thing, and that it creates some accountability, that somehow people are just going to go for care that they need. But when it comes to these populations, oftentimes getting people to go seek care in general, they're usually not going to go to get care unless they really have to, until they're really up against it. And so this fallacy that somehow copays actually make the system work better for folks with low incomes was something that people pushed back on pretty significantly. There was also a recognition that any kind of new system that gets developed in this way, that much of the revenue that would need to be raised would be done through taxes, and that they wanted to make sure that there not be cuts to other essential social services in order to subsidize a system like this, particularly because, as mentioned earlier, social determinants of health are a huge deal for health and well-being. And they wanted to make sure that any kind of tax system be done equitably, and it doesn't disproportionately impact folks who currently have low income. Next slide. So going to this idea of upstream care and prevention, there certainly was a point brought up about the fact that if we can deal with some of the upstream issues that people experience, that it can help reduce costs down the line. But at the same time, that when we think about how we coordinate both health and social services, that while folks certainly agreed with that in principle, they certainly also recognize the fact that both systems are extremely big. They have their own sets of needs, and that there would need to be a lot of careful thinking about how that would be done. There was some fear that both systems are so big that trying to combine them too fast and too soon would create even more confusion. And so there was certainly support in theory, but a lot of trepidation in terms of how that actually gets implemented. Next slide. Care navigation and access was a big thing that came up. You know, that the new system needed to have a much more formalized way in which system navigation actually works. That because Californians with low incomes have such a very difficult time trying to navigate and utilize care, that the way system navigation typically operates now is it's almost done as a way of advocacy, that the system doesn't necessarily incorporate it as a matter of policy, but that, you know, you've had groups that have actually been forced to come in and advocate for folks to be able to understand how to navigate through the system and to be someone to kind of lead them through how things work. And that there was an opportunity to flip that on its head and actually make that a part of the system so that people would be able to utilize it much more simply. And on that level, the fact that community-based organizations should have a much more formal and influential role in terms of how the system operates, in terms of thinking about policies, in terms of thinking about function and decisions being made, that rather than have community-based groups, which currently tend to be a more informal role, that they should really have a seat at the table given their level of cultural competency and relationships that they have, and that it would actually create a much better system than we experience today. Because folks with low incomes tend to move around a lot, that it would be important that there be some level of records portability so that folks can have greater continuity of care. And then finally, you know, when asked about the question of choice, folks felt that it was very difficult to try to choose or to try to prioritize access versus choice, that because cultural competence plays such a big role, which I'll talk about in a second, that both are in many ways equally important, but that access is only as good as the level of competence as a provider. Next slide. So accessibility and logistics was really highlighted as something that can't be ignored. That the fact that many folks who are lower income have difficulty with transportation, being able to get someone to watch their children, the fact that they often are unable to take time off work to get care. These are all real issues that are barriers, and that any new system has to be realistic in terms of what they're going to do to help create pathways for this patient population to not be hindered by these issues. There was also an interesting conversation about the value of telehealth, particularly as we've gone through the pandemic, and that while in theory it can be seen as something that can help alleviate particularly the transportation issues that people experience, the other flip side to that is that many folks don't have the Wi-Fi access that's required. They don't have necessarily the skills to access this, particularly when we're talking about older adults who have trouble and don't necessarily have the same level of competency around technology, that if they're relying upon telehealth, that they're probably not going to get the care they need. Next slide. So cultural competency was probably one of the biggest and most vocally or most vocal issues that came up throughout the course of all our interviews and surveys. The fact that there needs to be greater standards that dictate what cultural competency gets included, and that cultural competence should not be considered an option. It really needs to be a mandate with any new system. That right now Patients will often forego care when they know they're going to experience a provider that doesn't speak their language, who doesn't know their community, that they just fundamentally don't think that they understand, and that oftentimes being able to get that competency is a huge an important aspect of being able to get the care that people need. And so being able to develop those partnerships with community-based organizations is one pathway to that, but they also talked about the fact that we need to really think about what kind of pipeline we're going to create for the healthcare workforce, what sort of training needs to be done for existing workers. How do we make sure that there's, particularly when we think about areas in the Central Valley and other places where they already deal with shortages of healthcare workers in general, much less folks who have competency, that we can't create a system that doesn't address that piece. And then finally, and I think this is something that Kieran and others mentioned, we need to have a process that allows folks to have greater ownership and be able to be part of the system redesign, that there needs to be folks with lived experience, there needs to be people in the room that have direct context about what goes on in order to help influence the kinds of operational policies that'll lead to a better system. Next slide. And finally, a few other issues that came up that we wanted to highlight. One is related to Indigenous and Native communities, that there were specific cultural forms of care that needed to be recognized and compensated for and provided, that would be of a special importance to this community. And we heard the same thing with the Asian American Pacific Islander community, that there's many Eastern-based healing practices that are of great value to this community, but that if you try to go through your health coverage program now, it's not covered, it's not provided, and that folks have to often seek that care outside of their coverage. The LGBTQ community also emphasized that, particularly for themselves, that cultural competency is especially important, not just in terms of the kinds of care that they're able to receive, but even in terms of the way forms are provided, the data that's tracked. We heard, particularly when it comes to mental health, that there's significant trauma among the LGBTQ community, that they have very little recourse to find a mental health provider who has that level of knowledge and experience that are really going to be able to support them in the way that they need. So how do we start to fix that? And then finally, and certainly not, and certainly just as important, we heard a great deal from those who represent the disabled community. The fact that this is a community that tends to often be ignored, that is often not heard, that is often overlooked, and what needs to be done in terms of the way we operate a system that is more respectful but responsive to that community, and thinking about everything from having more folks with lived experience at the table for decisions, the kinds of care that's provided, but even thinking about the physical infrastructure of healthcare settings, the fact that folks who may be wheelchair bound often have trouble, navigating through a provider's office or through a hallway, and those are things that need to be considered as we look to the creation of an updated system. So that concludes my remarks, and I'm going to actually turn it over to Marisol Avina from the California Endowment, who's going to facilitate our Q&A.
Thank you so much, Paul, Dave, and Kieran, for that great presentation. Very rich data. And thank you all for joining us today and for putting in questions. If you have questions and haven't put them in the chat yet, please feel free to do so. We're going to get to as many of them as we can. So let's jump right in. So let's start. There are a couple of questions here regarding the findings. And so let's go with a question specific for Dave, I think. This is the research. Did it look into modalities of care? And will Californians continue to embrace telehealth beyond the current public health emergency? This is from Anna. Hi, Anna. Thank you so much for being here. And maybe Paul can also chime in on this question.
Yeah. We didn't include a lot of survey questions that asked a lot about modalities, but we did in the research ask people to tell us in the qualitative research about something that was working really well in the health system for them. And among the Californians with lower incomes that we interviewed, the thing they mentioned more than any other was telehealth. There was incredible gratitude for having opportunities to get care electronically, both because of the risks posed by the pandemic, and also because for many of the populations we're talking about, it's hard to get in-person care even in the best of circumstances when we aren't facing a pandemic. Many of them said that telehealth they hoped would continue and expand dramatically. So it was really striking the degree to which that was volunteered and offered up by our respondents as a sort of a positive change that they had seen in the health system.
Great. Paul or Kieran, anything you want to add to this question? I know you've both of you have done some work or inquired on this specific topic.
Yeah, I'm happy to go ahead,
Go ahead,
Paul.
Kieran.
Okay, I'll go first, then you. It's an exciting topic. Everyone has something to say. So I'll just say we have done some research at CPEN, some surveying specific to communities of color, because I think we had a lot of questions at the beginning of the pandemic, like, is telehealth working as well for everyone, right? Or are there challenges? And, you know, I'd say overall what we found is that there's really, really high satisfaction in communities of color. In fact, at least in our surveying, higher satisfaction than in white communities. And I think a lot of that has to do with being able to remove some of those access barriers to make it take less time, right, to see a provider, to make it easier to get an appointment, all of those things. But there were still, I think, really significant challenges that the state is going to need to overcome. And language access was actually a big one, which is always surprising to me because I thought it would be easier to coordinate on technology. But a lot of people not getting the interpreter services that they needed. And of course, the broadband digital divide issues, but also people just not having the support to utilize the technology, right, was what we heard a lot about, like that consumers are going to need some support from people on their care team to figure out how to use the technology. Particularly our older adults are really struggling with that. So I would say overall, yes, it's here to stay, and that's mostly embraced by communities, but we do need to really focus in on solving some of those challenges.
Yeah, the only thing I would add is I think what we heard from community-based organizations is telehealth can't be seen as the panacea, that it needs to be thought through much more carefully, to be considerate of the challenges that people have on the back end to access telehealth, and that without dealing with those, you know, telehealth is not going to fully realize its potential. And so I think that there's certain populations that were cited as more able to receive telehealth as opposed to others, as Karen mentioned, like older adults. It's harder for them because of some of the technology skills that are required. But then when you think about like immigrants and farm workers, the Wi-Fi and connectivity things are a huge deal. So I think that there's certainly is opportunity with telehealth from what we heard, but we also heard that until you deal with some of these other issues, that we have to be mindful of the fact that telehealth is not going to be a one-size-fits-all approach.
Great, thank you. So the next question is related to workforce, and I'm going to reframe it a little bit because I don't know that we can respond to the question the way it was framed. You know, it's currently asking how well will California healthcare system respond to the issue of the Great Resignation or people leaving workforce. But so what did we hear from maybe a community-based organization interviews? And then Kieran, I'm sure you probably, CPEN has done some work on workforce. So what are we hearing as to what, you know, Californians want to see in the healthcare system as it pertains to workforce?
Yeah, what we heard, I mean, we heard a ton. Workforce was one of the most talked about issues that came up, and particularly related to cultural competence. And I think that's really the key, is that there needs to be a much greater connection point between cultural competence and workforce. That we just can't keep producing doctors and nurses and other healthcare providers. That there needs to be a competency that's instilled on them, so that we're able to be better responsive to the diversity of the state, and that as we think about creating this new system, there needs to be an equal and also focused effort on how we deal with workforce in terms of training, in terms of developing a pipeline, in terms of creating expectations about what kind of competency is necessary, and how do we make sure that it's more greatly accessible. And so there was certainly a discussion among folks we spoke to saying, look, we realize that this is in some ways its own issue, that almost lives a little separate and apart than just sort of the core service provision and coverage models and all these other things. But they said we can't divorce ourselves from each of them, that you can have a perfect operating system on one hand, but if the workforce isn't there that's competent enough to deliver care, then the system's going to fall apart.
Yeah, I think the thing I would add is we always see that there's a lot of interest in communities of color, people with low incomes in actually joining the health workforce, but people don't have access to those opportunities. And so I actually think there's a problem here, but there's also a huge opportunity, which is both an opportunity to diversify the workforce and to provide greater economic mobility in communities by really creating some of those pathways and pipelines to healthcare programs. And I think one of the things that we always emphasize too is physicians are very important, and we need other types of providers that meet the needs of diverse communities. And so really focusing on, what are our opportunities for people to become community health workers or health navigators or peer providers, that some of that is a really important but sort of underinvested part of this conversation.
Thank you. Thank you so much for those responses. So Rocio has a question. Rocio, thank you so much for joining us. So the question is, did the research uncover how we can prepare our medical system for the growing and ethnically diverse aging population? So let's see, was there anything in the existing research maybe, Kieran?
Well, so I don't know that this is really contained in the report or the presentation. It's a good question. Hi, Rocio. I think, a couple things, though, that come up a lot is this idea that we need to think a lot more about caregiving and have a much more expansive definition and much more investment in caregiving, because our population in California is aging, and it's also becoming much more diverse, right, as people age. And so there's different challenges that come along with that, but also, again, real strengths and opportunities, right? So I think some of the things that we hear about even outside of this work, one really is thinking at that role of both professional and family caregivers and how we invest in and strengthen the support that we provide for that critical role. And I think the other one is really making sure that we have a healthcare system that is competent about age and aging, right? There was some research that came out just today about, I think it was today, I just saw it today, about the number of seniors who report that they feel that they experience discrimination in healthcare settings because of their age. And when you look at the nexus between that and race, I think it's particularly striking. So again, making sure that we are both providing the training to providers to ensure that there will be that competency at the intersection of age and race or any other factor, and that we have, I think, an increasingly diverse workforce that can meet those needs for families.
Thank you, Kieran. There was a question about electronic health records. And so Casey asks, is there interest on the part of patients for a single EHR across all California healthcare providers? And I think we touched a little bit on it, but Paul or Kieran?
Casey's got all the hard-hitting questions today. So, I mean, the thing I can say about the EHR, I don't know that that is how consumers think about it. But what we do see is, one, there's a lot of information that consumers want their provider to know more about them and to have a more holistic understanding of their health, their well-being, their situation, but also to know more about their community and sort of their culture, their circumstances, all of those things. We also see a lot of consumers wanting more integrated care. And again, that's not only being able to go to one place, but that's really being able to have a level of information sharing between providers that will assist you in your care. So I think, you know, again, I don't think that's how most people are not thinking about a unified EHR or defining it that way, but some of those same needs. But I will say there's also concern, right? And particularly when you think about consumers who have a mental health or substance use need, people don't always want that information shared with, for example, their primary care provider. People might experience discrimination based on their mental health condition, right? And so I think it's a place where there's a lot of potential for the state in terms of thinking about how do we make sure we have the right information, both on an individual clinical level, but also on a population level, to be able to make the right investments and really to be able to tackle health disparities. But it is something that needs to be done carefully.
Yeah, just to add to that, Marisol, particularly to that last point, you know, because folks have experienced discrimination and bias in the system, there's a real trust issue that comes up. And the fact that while their advocates talked about portability of records, they also talked about that sometimes information is used against community members, against the patients. And so, you know, when we talk to folks who represent the disabled community and some who have very lived experience themselves, they were saying, look, you know, we find ourselves in situations where our disability is used as something that the system uses against us, so that we're not in a position to make decisions for ourselves, where we're not in positions to think about the kind of care that we really need, or to be influential in terms of what's going to happen, that they see us as less than. And so while information can be helpful in terms of creating greater continuity of care and more consistency, there's also needs to be greater protection so that community members don't feel that that certain information is going to be used in a negative way or misinterpreted in some way that actually is going to hurt them rather than help them.
Great. Thank you so much for that, Paul and Kieran. So we're going to take one last question here, and it's going back to telehealth. So probably more specifically for Paul, if you ask this, or if it came up during the interviews, but Kieran, you may also have a response to this, but this is pertaining to the differentiation between video-based and audio-only telehealth services, and whether the respondents had different views for audio-only visits.
You know what? We didn't hear much distinction in that way, Marisol, about you know, audio versus visual. I think fundamentally it had to do with just technology for one, and then I think as Kieran pointed out, you know, when you think about language access, you know, and that's going to come up whether you're on audio or video. You know, is if the person on the other end doesn't have the language competency to engage that patient, it's going to be a problem. And so so we didn't hear of anyone saying, well, you know, we think audio would be better than video, or vice versa. We do, what I've heard sort of anecdotally and separately, is because the provider-patient relationship, there's such a intimacy that goes with that, and the level of vulnerability, that certainly being able to have a more physical presence can be an important aspect of building trust between the provider and the patient. I think we've all experienced during the pandemic how it's been a mixed bag of dealing with trying to interact with people and trying to create that relationship, folks, when you've never met them, and it's all being done virtually. And so I don't know what has been looked at more intentionally about, what is that going to mean in terms of creating that level of trust moving forward. I think that in some ways, when I've heard telehealth being provided, it tends to be almost looked at as sometimes in combination with in-person health as opposed to a complete substitute. And so, but I think those are all questions that need to be addressed and as we look at this more expansively.
I mean, the only thing I would add, and I'll be super quick, is that I think, one, there's still challenges with audio, and we actually got a lot of folks in our survey saying like, hey, I don't have enough cell phone minutes for audio. So I think we need to be conscious that it isn't a complete solution to folks who are having difficulty with video, right? But I think the other key thing that we have as a takeaway is that it always needs to be a consumer choice. It needs to be a consumer choice whether you're using telehealth at all, and it needs to be a consumer choice whether you're comfortable with video or audio, as kind of the key thing that we hear from folks.
Great. Thank you so much, Kieran. And then just lastly, I'll respond to the question regarding the slides. So yes, they will be shared. If we have your email, so if you registered for the webinar and we have your email, we will be sending out the slide deck, the recording, and then a link to the report. So with that, let me turn it over to my colleague, Bonnie, who will be closing us out. Over to you, Bonnie.
Good. Thanks, Marisol. Thank you, first of all, to our researchers, our partners who completed this work in a very short amount of time. So Kieran, Dave, and Paul, thanks again to you and your teams. There was a great question that was raised by Max, which was, so what's sort of next with this data? Certainly we heard an invitation from Dr. Galley around continued engagement. I know many of you represent organizations who work with communities who have a vested interest in what the health system looks like here in Californians, and one that works for all Californians. So we encourage you to stay active, get involved in attending commission meetings. Certainly there are other conversations happening around this data as well, which we think this data is valuable to those. So while the data was produced sort of with the intent to bring in voices to conversations that are happening now, it doesn't have to stop there, and we encourage you all to spread and share this data too. This report that was produced will be a part of the commission report that gets delivered back to the legislature at the end of the commission process. There is also a link at the bottom of your screen right now to where you can find the report. So again, thanks to our researchers, thanks to our funding partners at the California Healthcare Foundation, California Community Foundation. We hope you enjoyed this webinar, and be well, everyone. Thanks.